Lots of words on here. Shout out the answers.
Huh.
Give you D, delta. So, pericardial thickness is more accurately measured by echo than by MRI. They're about the same. Okay, so I wouldn't say that the ultrasound or the echo is better than MRI. It's about the same. Gadolinium enhancement is a contrast technique used with cardiac CT scan. Gadolinium is the MRI contrast, not the CT contrast. So that's why that answer is incorrect. During nuclear imaging, technetium-99, blah, 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 they are taken up by regions of infarcted tissue, but not healthy myocardium. That's the opposite, right? Infarcted is dead tissue, so it's not going to take up really blood flow, right? It's dead. So it actually does the opposite. So doing that perfusion scan with the radionucleotide, it will be taken up by healthy tissue or hibernating tissue, which is just sleeping tissue, but won't be taken up by dead tissue. So that leaves us with cardiac MRI can distinguish between blood, fat, and myocardium without the administration of contrast agents. So remember, that's one of the advantages of doing a cardiac MRI is that you may not need to give contrast to get a lot of the information that you want. So that's why delta is the correct answer. How about this one? So which of the following is an absolute contraindication for an exercise stress test? Remember we talked about active problems or absolute contraindications. So maybe that might help with that. Bravo. We have active endocarditis, which we're going to talk about endocarditis today, right? Active endocarditis, absolute contraindication. Otherwise, there are some relative contraindications for doing a stress test, but relative means that there is a window that you could do this in special circumstances or situations. So, but absolute, the only real problems are things that are actively going on in the patient. And then our last one is, which of the following is an indication for a right heart catheterization? What are your thoughts? Okay, I'm hearing C or Charlie. Do people agree with that? Okay, I agree with that as well. So right heart cath is a diagnostic only cath. It's not a therapeutic cath. And it's there really to help you with like monitoring, especially in critically ill patients. Helps you kind of see what's going on with all their different values so you can better manage them. So Charlie is the correct answer. All the other ones define coronary anatomy. If the openings for the coronary arteries come off of the aorta, the root of the aorta, probably need a left heart cath to do that. Evaluation of left ventricular function, again, left heart cath to gain access to the left side. Proximal aortic disease, left side. Assess unstable anginal symptoms. This is maybe the one you may be questioning on, but the unstable anginal symptoms, kind of think of that as a STEMI or a heart attack, right? So you're going to want a left heart cath because you want to see what's going on in the coronary artery anatomy. So that's why echo is not the correct answer. So, make sense? Okay. So let's start off today's lecture talking about a clinical case that I was involved in when I was a resident at Fort Belvoir that caused us a lot of sleepless nights trying to figure out how to take care of this patient. So the scenario goes, we had a 55-year-old postmenopausal female who presents to the ER for 3 days of fatigue, low-grade fevers, and lack of appetite. She was previously healthy and had no sick contacts. COVID-19 is at the height in DC in the area. She came to the ER. She was found to be febrile. She was intermittently hypotensive, but she was responsive to fluids. She was lethargic appearing and weak. CBC showed leukocytosis and a mild thrombocytopenia, and her COVID-19 test was negative. At that time, because it was early COVID, you needed 2 negative tests 24 hours apart to be able to say that this person, in fact, was COVID negative, okay? So that kind of gives you some of the background on why she was admitted to the ICU, which was our COVID-19 isolation unit at Belvoir, because the thought was that she had early COVID, and that's why she was feeling these vague kind of symptoms, with low-grade fevers, and with the thrombocytopenia. I came on, I got report, I went upstairs with my team, and about 5 o'clock, and then about 6:30, I received a call from the lab that said that her blood cultures had already popped positive. 3 out of the 4 vials had already been become positive for gram-positive cocci in pairs and clusters, and this is less than 10 hours after they were drawn. So this either means it's a contaminant, meaning they didn't prep the skin and get rid of the bacteria on the skin before they punctured the needle through the skin, or this patient is very sick and has such a high bacterial load that it caused the culture to be positive. Because normally it takes about 48 hours to get any kind of results with blood cultures. Okay? But within 10 hours, she was positive. I quick opened up her profile, started looking at her vital signs, and I noticed that they've been recording periods of hypotension where her systolics were in the 80s, like low 90s, and she kind of would dip down, they give her some fluids, and then it'd go back up, and she'd be okay, and then it'd dip down again, and we were just kind of chasing with IV fluids this hypotension. She was febrile to 103, she was sinus tach. I head down to the ICU and I start talking to the patient's nurse, and the nurse noted that this new rash had started to develop on her hands and feet. And this is what we saw. On the left-hand side, this rash was painless, and on the right, it was painful. Okay. And then, oh, by the way, her feet started to develop this rash. So it looked different. So I have 3 different things going on in this one patient who was admitted for COVID-19. Okay, didn't make sense. And we'll come back to that clinical case at the end of the lecture. So, endocarditis. What exactly is infective endocarditis? Basically, it boils down to, it is an infection or inflammation of the endocardial surfaces. Recall from our first lecture, what is the endocardium? It's that innermost layer of the heart that lines the chambers, the valve structures. It's even contiguous with the blood vessels, the arteries and the veins. So that's your endocardial surface, or the endocardial cells. Well, infective endocarditis is just an infection or an inflammation of that layer. So that kind of points to wherever there is endocarditis, you can have this infection. Okay. So most commonly, when somebody does develop infective endocarditis, it typically involves the valves and the valve structures themselves, but the walls of the chambers are also surrounded by endocardium, and they are also susceptible to get this infection or have complications from that infection affecting those structures as well. And then you also tend to have a vegetation that forms, which kind of think of this as a very complex, like localized abscess that is present in the area. And we're going to see what that looks like in a couple of slides. But when you go to classify infective endocarditis, you can classify it in 3 different ways. The first is talking about the clinical course. How quickly did these symptoms develop and lead to the presentation of this patient? So you have acute bacterial endocarditis, which is a rapid development. They go from they're fine to they're very sick within a short period of time. So imagine if somebody goes from being okay to being very sick quickly, is this a aggressive bug or not? Yeah, what's a perfect example of an aggressive bug? Staph, i.e. also MRSA, right? Methicillin-resistant Staph aureus. So when somebody has an acute endocarditis, be thinking of a staph infection. If I have subacute, where it's days that they just kind of are not feeling very good and slowly getting worse, that is a subacute bacterial endocarditis, and the strep species tends to be the cause. Strep is not as vigorous, it's not as bad of a bug as staph is, so it's a slower onset kind of infection. So that's the clinical course way of classifying this. The next way is to define what are some of the risk factors for why this patient developed infective endocarditis in the first place. Do they have the heart valves that they were born with, okay, native valves? Or did they get a valve replaced and they have foreign material for a foreign heart valve in there instead? Because if I have a foreign body, does that make sense that that's going to make me higher risk for an infection, right? Your body tries to fight off foreign things. Same goes with bacteria. It gives a good surface for it to bind to and then allow the infection to take hold and go rampant. So a prosthetic valve is another way you get this. And then the third way is IV drug use. Do IV drug users use proper sterile technique to inject their drugs? No. They often are not cleaning it properly. They may be in environments that are not sterile. They also tend to reuse needles, right? So, or the drugs themselves that they're injecting are contaminated. So does it make sense that if somebody is doing this stuff, injecting drugs, using dirty techniques, dirty instruments, dirty drugs, does it make sense that that's also going to put them at high risk for an infective endocarditis? And when we look at what types of bacteria or organisms can cause infections in IV drug users, you'll see this actually tends to be a very bad form of infective endocarditis. The third way is, well, what kind of organism is causing it? Is it gram-positive or is it gram-negative? Okay, that kind of makes sense, right? From your micro days in freshman semester to even now your infectious disease lectures that you're receiving now. It makes sense that that's how you're going to classify a bacterial infection based on their gram-positive, gram-negative status. But when you use these ways to classify, these are not mutually exclusive. It's not like you can just say, this is an acute and that's it, right? You can say that this is a gram-negative, native valve, acute bacterial endocarditis. So you can kind of see, as I'm giving more and more information, I'm kind of steering you to what the most likely organism is going to be, but then that can then lead to what the best treatment options are for that condition. Now, talking about infective endocarditis, in the United States, we have about 10 to 15,000 new cases every year. So it's not very common. 10 to 15,000 seems like it's a lot, but when you think of the population of the United States, it's only about 10 to 15,000 new cases each year. So not very common. The majority of the cases tend to be in patients who are elderly or over the age of 60. When we talk about risk factors, we'll see why that tends to be the case. They also tend to have, patients tend to have pre-existing cardiac conditions. So we said like an artificial valve or a prosthetic valve is a risk factor or a way that we can classify it. Imagine that patient who has had a valve replacement procedure done in their past, they're probably more likely to get this infection than if they don't have that. Community-acquired infective endocarditis. Typically, it will affect the left-sided structures, so mitral valve, aortic valve, but it also tends to be a less aggressive bug, so strep species is typically your community-acquired version of this. Hospital-acquired, we always are concerned about MRSA with hospital-acquired infections in general. So if you have somebody who was recently admitted to the hospital and then they developed infective endocarditis, be thinking of MRSA as the potential cause in that patient. And then when you got IV drug users, instead of this being more of the elderly people, what's the stereotypical age of an IV drug user?
30s.
Probably late teens, 20s, 30s, right? So the average age of an IV drug user having infective endocarditis is going to be in their 30s, okay? Because that's the age that they're putting themselves at risk of developing this condition in the first place. What's different though about IV drug use is it's most commonly actually a right-sided infection, not a left-sided like it is in community-acquired and in MRSA. So you're talking about now right-sided structures like the tricuspid valve being impacted by the bacterial infection. So what are our risk factors? So we said most commonly in patients ages greater than 60. Okay, so that's going to be a risk factor for it. Males in general, because when we talk about, as we continue on doing the additional blocks, you'll see the male gender is a major risk factor for a lot of cardiac conditions. So males over the age of 60, if they have a history of structural heart disease or they've had a valve replacement, that all puts them at a higher risk. We'll talk on Friday about congenital heart disease, but having a history, especially if the condition is still present and hasn't been fixed or corrected yet, that puts that patient at a high risk of developing infective endocarditis. And then, okay, we talked about IV drug use. If you've had it happen to you once before, there's a higher likelihood it's going to happen again, so a repeat offender. And then poor dentition or dental infections can put somebody at a much higher risk, which is why I've got the meme on there about your dental habits. But dental procedures, dental infections puts somebody at much higher risk of developing this condition. But to develop infective endocarditis, it's more than just bacteria enters the bloodstream. If it was as simple as bacteria gaining access to the bloodstream, that 10 to 15,000 cases in the United States annually would be much, much higher. Because look at how many patients are admitted to our hospitals every day with sepsis. Sepsis is bacteria in the bloodstream, right? So we would have hundreds of thousands of cases of infective endocarditis if it was just as simple as they have bacteremia or bacteria in the blood. So what has to happen in order for that patient to develop this condition? Well, the first thing is you have to have some type of injury to the endocardial surface. So it's not a specific thing. It's really anything that can cause damage to that endocardial surface. The next step is that damage that's done is bad enough that it triggers a healing response from the body. So they get a blood clot that forms to try to heal that damaged area. Now, the problem with it is when you do have that blood clot that's formed there to try to heal the area, and you happen to have bacteria in the blood, that clot creates a great environment for that bacteria to, one, gain hold, but then to start to propagate and kind of remain hidden from your body's natural immune response fighting abilities to get rid of that bacteria. Okay, so you kind of, that clot kind of forms a protective shield around the bacteria. And then with all of that, the bacteria, the clots, and the healing processes happening all at the same time, creates this very complex structure that you can kind of see here. It's made up of things like platelets and fibronectin and fibrinogen and all that stuff that then leads to this formation of a vegetation, which is just that bacteria involved or embedded in that clot. And this is an example, this is actually a real example of what a vegetation could look like, okay? So here's the vegetation. Here's your heart valve. What you see here is there looks like there's some suture. So this is probably a patient who has had a heart valve replacement procedure done in the past. So that puts that patient at a higher risk of developing this condition in the first place. And then they had that endocardial damage that led to that clot formation, which then they had bacteria in their bloodstream that then created this vegetation that you see there. That is not, I don't know if anybody has ever seen an abscess before. Abscess is just fluid, right? That just contains the purulent material, the white blood cells, the bacteria, all that kind of stuff. But it's like a fluid thing, right? Does that look fluid, or does that look solid? Yeah, and that's what a vegetation is. It's a solid structure. But the other thing is, imagine the complications that can develop from having this vegetation growing through the cardiac valves. Is that thing closing? No. It's remaining open because it's forcing those leaflets open to accommodate that vegetation growing through the opening. So now you have, instead of a one-way integrity of the cardiac valves, you now have blood that's refluxing in the wrong direction, depending on which valve is affected by this. Okay? So there's complications that will develop, and we'll talk more about the different types of complications later in the lecture. So who should you suspect has infective endocarditis? You have a patient who has a prolonged fever and you can't find another source, be suspicious for endocarditis. Also be suspicious if they start to develop other types of weird symptoms. So like evidence of like embolic disease. They have strokes, or they start losing, a digit starts to look like it's going to rot off and die because the blood flows permanently or completely affected go into that digit. If you do a blood culture, you put them on antibiotics, and then you retest the blood culture in 24, 48 hours, and that is positive as well, then be suspicious for infective endocarditis. Other things would be a part of your history. Okay, if they're an IV drug user coming in with a fever, be very scared that they have this condition. That patient needs to be treated for infective endocarditis immediately. But there is a tool to help you determine and have a pretest probability of whether or not this patient has infective endocarditis or not. It's called the Dukes criteria, or modified Dukes criteria. And I don't expect you to memorize all the components of the Dukes criteria, but what I do expect you to know is that for somebody to be listed as having definite infective endocarditis, they need to have at least 2 major criteria positive, or 1 major, 3 minor, or 5 minor criteria positive. Okay, so you got to know that. If they don't meet the definition of definite infective endocarditis, you can say that this patient has possible endocarditis if they have 1 major, 1 minor, or they have 3 minor symptoms or findings. If they don't meet those criteria, then it is highly unlikely that this patient has infective endocarditis. Okay? So what are our major criteria? Again, I don't expect you to memorize this, okay? You have calculators in your phone, which if you don't have the app MD Calc already on your phone, I highly encourage you to get it, because it is a great tool for you to take data and create create a objective result to justify your clinical decision making, okay? So I'm not gonna expect you to memorize this because you just can look this up. Just recall Duke's criteria, what the requirements are to be definite infective endocarditis based on the Duke's criteria, or the possible infective endocarditis. Okay? But when we look at the major criteria for Duke's, you have to have a positive blood culture with a bacteria that can cause infective endocarditis. Okay? That kind of makes sense, right? Why should I suspect infective endocarditis if it's not a bacteria that can cause infective endocarditis? So there's a lot of different kind of things. So strep viridans is a key one because it is a dental bacteria that can put you at high risk for it. We already talked about Staph aureus just because it is such a nasty bug. The other criteria would be persistent positive blood culture defined as recovery of an organism consistent with, i.e. with blood cultures that are drawn at least 12 hours apart. Or if you have a single positive blood culture for Coxiella, that is a major criteria for infective endocarditis. Another criteria is you do an echo and you happen to see a vegetation on a cardiac valve or a cardiac structure. You would think that then you would only need one major criteria, but technically, according to the Duke's criteria, you need at least two to be able to say that. And then another criteria is they have a new valvular regurgitation, which recall from the picture of the vegetation I showed you why somebody might be prone to having regurgitation if they had infective endocarditis. Here's the minor criteria. So remember, you either have to have one major, three minor, or you have to have 5 minor criteria in order to meet the Duke's criteria for infective endocarditis. And the reason that these are minor is these are very non-specific. Okay, so fever, great. How many other conditions have you learned since you got here that fever is a symptom of it? All of them, right? If you have kids who go to daycare, every day they're coming home with a fever, you don't suspect they have infective endocarditis every time they come home, right? So that's one of the minor criteria. Predisposing heart condition or intravenous drug use, okay? Vascular phenomena and immunologic phenomena we'll talk about. Those are pathognomonic for infective endocarditis, but those are only minor criteria, which kind of doesn't make sense that if this is what we typically see in infective endocarditis, why isn't that a major criteria? I don't have a great answer for that, other than they are not even very common in your patients with infective endocarditis. So, when you have a patient who you suspect has infective endocarditis, you've got to make sure you do a great history, to include surgical history and substance history. You've got to see, are they injecting IV drug use? And maybe it's not even IV drug use. Maybe they are doing injections of whatever for whatever reason, i.e. they're undergoing fertility treatments and they're doing self-injections. Maybe they're on their GLP-1 trying to lose weight and they're doing self-injections and maybe not preparing the site properly, okay? So don't lock in on just IV drug use. There are other things that are injectable that would put somebody at risk of developing this condition. Detailed exam. So you've got to make sure you're doing a head-to-toe kind of assessment because you're looking for any kind of physical exam findings, complications, or anything like that from infective endocarditis. And one of the key things you need to do is make sure you're auscultating the heart and actually taking the time to listen, especially for regurgitation murmurs, okay? Because when I look at the 2 most common symptoms that patients with infective endocarditis are going to present with or you're going to find on physical exam, fever is present in 80 to 90% of patients. Okay, but we already said fever is not a very specific symptom. Heart murmur is present in 80 to 85% of your patients. So this new heart murmur just suddenly develops. Be suspicious for infective endocarditis. But look at the things that we pathognomically think are infective endocarditis if we find it on our physical. These are your Osler nodes, your Janeway lesions, Rot spots, only found in about 2 to 15% of your patients with infective endocarditis. So not a very common presenting sign you're going to see in your patients with infective endocarditis. Okay. But because a lot of those symptoms are vague, and okay, fever, yes, happens to everything else. I can easily dismiss it as I have a viral respiratory infection, whatever. How many patients are going to be able to tell you that they have a new heart murmur? Probably not, right? Somebody's going to have to listen to their heart to tell them that they have a new heart murmur. So the symptoms are very vague, very non-specific. So your patient may not present to you until they have developed an additional complication from the infection. So what are the complications that could develop? So the regurgitation murmur, that's part of it, but the consequences of that regurgitation. So they could be presenting in heart failure because they have such a large, drastic, sudden regurgitation that the body and the heart cannot keep up with that volume. And they present with that volume overload. They could present with evidence of embolic disease. So this could be a stroke, but it could be that it goes to other structures too and includes like the small arteries to prevent blood flow to that, i.e. like the kidneys. Okay. And that's your septic emboli that you see here. And you can see, the percentages of patients who are going to experience some of these additional complications from that. The emboli themselves, they are coming from the vegetation and having little things kind of chipping off of that vegetation. Okay? So think again about that picture of that vegetation I showed you coming through that cardiac valve. If just a small part of that were to break off, where would it go? Depends on which side of the heart you're on, right? If you're on the right side, it's probably going to the lungs. If it's on the left side, it could go anywhere in your arterial system and potentially cause an occlusion of a vital organ, for instance, the brain. Okay. So that may end up being your presenting symptom of somebody with infective endocarditis having that complication there. So what do you do if you have a patient who you suspect? Well, blood cultures is a major thing, right? Why do we want cultures before we start on antibiotics? Exactly. You want to know what you're treating, and you want to know what's going to work against what you're treating, right? Why should I throw an antibiotic if that bacteria that that patient is suffering from is not going to respond to that antibiotic, right? You want that culture, and then the sensitivities part to that culture gives you that information you need to make sure you have them on the correct regimen. So do blood cultures, and ideally we want blood cultures before they've been started on antibiotics. Oh, but doc, I just started the IV and then I got my blood cultures, but it was only 2 seconds that they were getting antibiotics before I took the blood cultures. That should be fine, right? It's not necessarily that that antibiotic started to kill the bacteria, but if I have a little bit of antibiotic in my blood sample, that is going to prohibit and interfere with the growth of the bacteria in that sample, and that's going to give you potentially a false negative result. Okay? So that's why you want to get a culture, and this goes for any culture, you want to get that culture before you start antibiotics to be able to give you the most accurate results with this. So do blood cultures. Do a complete blood count in the CBC because I want to see what their white count looks like. Remember also on the differential part to your CBC, you're going to be able to see is this neutrophils. That kind of makes me think that this is a bacterial infection. Or is this lymphocytes that maybe this is more of a viral infection, okay? So looking at the CBC, the platelet count is also going to be important because that may start to drop as that patient gets sicker. So that platelet count will be important. Or it could also be part of that inflammatory process. You actually see that platelet count go up as an acute phase reactant. Same goes with like your ESR, CRPs, those being high as part of that inflammatory response. So you can get an either or with the platelet count in a sick patient. And then you want to get a basic metabolic panel because you want to see what the kidneys are doing because you want to make sure that there isn't a complication developing to that kidney function from this bacteria. And then you have to get an echo. Okay. Most of the time we will do a transthoracic echo to see if we see that vegetation on the cardiac valve or the cardiac structures. If we don't see a vegetation on the transthoracic echo, but you are suspicious for infective endocarditis, then you have to do the TEE, transesophageal echo, because it is a much more sensitive test and can get a much clearer picture of what's going on in the cardiac valves and the cardiac structures to be able to tell you whether or not this is infective endocarditis or not. So TTE, great. If it shows the vegetation, you got your diagnosis, that's all you need to do. But if it's the TTE is negative, then you've got to do the TEE to look further. And this fancy flowchart decision-making tree just basically comes down to if you suspect it's infective endocarditis and the TTE is negative, do the TEE. Okay, that's all I want you to know about this flowchart. Okay. But we talked about the vascular and the immunologic phenomenons that could develop. And we've thrown out some terms, but we haven't really seen examples of what that means, okay? So a vascular phenomenon, kind of think of this as the small parts of the vegetation get chipped off and then occlude small arteries or capillary beds, okay? So that's what causes a vascular phenomenon. And you have things like splinter hemorrhages and Janeway lesions that fall under that umbrella of vascular phenomenon. Now, immunologic phenomenon is now your immune system is binding to the antigens on the bacteria, and then this causes complications or occlusions of your arterial systems or other vasculature. And these are going to be your things like your Osler nodes or your Roth spots that you see in the retina. So what exactly do these look like? Here's a Janeway lesion. These are painless. It's a vascular phenomenon. Here is splinter hemorrhages. If you can't see it, just look at this right here, or this right here. Those little brown spots of brown areas, that is an occlusion of the capillary beds in the distal fingertips that cause that. You can see it from underneath the fingernail there. If you have somebody who has right-sided infective endocarditis, i.e. like your IV drug user, then they tend to have that septic emboli chipping off and getting sent to the lungs, and that can cause that bacteria now to gain hold of lung tissue and start causing problems. You can get these septic cavitary lesions. You can find that on your x-rays. Immunologic phenomenon. So we said Roth spots affect the retina. You can see on these examples the Roth spot, which is this kind of central cleared area right here that's surrounded by like this erythema. Here's another great example of that. Central clearing with surrounding of erythema. You see it here, you see it here, here. You can see it down here. That is a Roth spot. Okay. Probably not something you're going to see on your primary care physical exam of the retina. You probably need to have your ophthalmology or optometry colleagues come in, do a dilated eye exam, and do the retinal scans for you. Here are Osler nodes. These are painful. So they're like erythematous lesions, but are painful. And then other things that you might want to do is, okay, we talked about chest x-ray, looking for that septic thing. EKG, because part of the complication is if that vegetation were to start gaining hold and growing in the interventricular septum, what structures go through the interventricular septum? Bundle branches, right? What can happen if I damage a bundle branch? I can get all kinds of arrhythmias, or at least a bundle branch block, and those kinds of things. So your EKG may see some conductive pathway problems to warrant getting the EKG or being suspicious for infective endocarditis. Additional labs, okay, urinalysis. You may see proteinuria because of the glomerulonephritis as part of the response and complications from the infection. And then we talked about acute phase reactants there too. So lots of labs that you might want to do in addition to your echocardiogram to kind of evaluate further or to evaluate for complications associated with this. If you have a IV drug user, then be suspicious for tricuspid valve disease and be suspicious that it is MRSA. Okay, most common, MRSA. However, look at some of the other things that can cause infective endocarditis in a drug user. Pseudomonas, candidal infection. Imagine how sick those patients are going to be if they have one of those versions of infective endocarditis. Okay, so do you think the IV drug user with infective endocarditis is going to be healthy, or you think that they're going to be sick? Very sick, right? So IV drug users tend to be very sick because they tend to get the more aggressive bugs. If you have an older patient who has a native valve, so it's the valve that they were born with, and they have maybe poor dentition, or they have like dental infections, then be concerned for strep viridans. Okay, strep viridans tends to be one of the more common or most common causes of infective endocarditis in the United States, and it's usually in elderly patients with poor dentition because strep viridans is largely found in the mouth. If they have a prosthetic valve, then a less aggressive bug like Staph epidermidis may be causative. This is not Staph aureus, but because they have that prosthetic valve, they're at a much higher risk of developing this condition in the first place. Okay? And then if you have Strep gadalyticus, this is actually introduced in the GI tract and is concerning for colon cancer. So if you have somebody who's diagnosed with Strep gadalyticus or Strep bovis, then be suspicious of colon cancer. And this patient probably needs a colonoscopy before they are discharged from the hospital to diagnose their colon cancer. Okay. So how are you going to treat it? If you've looked ahead on the slide, you see I don't give you a bunch of antibiotics to memorize in order to treat this condition. This is not as simple as let me throw piperacillin tazobactam at them, or Zosyn, because it ultimately depends on what the most likely bug is that's causing it. Okay? So you're going to get your blood cultures, and then you're going to start empiric antibiotics against the most likely bug. And you get that by doing your history, seeing what their risk factors are, give you an idea of what is the most likely bacteria that's causing this infection in the first place, while you wait for those cultures to give you the definitive answer, okay? The other things you want to do is, you can't manage this alone. This is not somebody who's going to be discharged to outpatient therapy with oral antibiotics. They are going to be sick enough that they're going to require a hospitalization and probably need to actually go to the intensive care unit, okay? But you want to load your boat with expertise, so you're going to get cardiology involved because you're going to need them to do the echo in the first place, right? You're going to need infectious disease to help you manage the antibiotics for this patient. You're also going to want a cardiothoracic surgeon on board because we may need to do surgery to remove that vegetation. One of the key things or key concepts of sepsis management is source control, right? I got to get rid of the source of that infection. And in infective endocarditis, it's that vegetation. So I may need to get that surgery, that cardiothoracic surgeon on board to do an open heart surgery to get rid of that vegetation. Okay? Doesn't necessarily mean that they need it. Hopefully, you loading a bunch of good antibiotics is enough to get rid of it, but you need that surgeon on board early in case it doesn't happen. And you're going to have them on antibiotics for a long time. This is not your 5-day, 10-day, 14-day antibiotic course, okay? You're going to have them on it for weeks. So 4 to 6 weeks usually is the treatment. Because does it make sense that if I have bacteria in this very complex vegetation structure, just a quick, short course of antibiotics is not going to be enough to ensure I get 100% kill ratio of bacteria. I'm going to need a much longer course. And this is not 4 to 6 weeks of oral antibiotics. This is 4 to 6 weeks of IV antibiotics. Okay. But you got to be aware of the complications. You need to counsel your patients about the complications associated with this. Because the complications are, okay, the regurgitation they have may lead to heart failure. They may start having that vegetation chipping off and leading to emboli, or it may cause a lot of other things. But if they have poor dentition, then they need to be seen by a dentist in the hospital. One of the few times that we actually call a dentist to come see an inpatient is in infective endocarditis, because I need them to look at the teeth to make sure there isn't a tooth problem that led to infective endocarditis, especially since in the United States, the most common form of endocarditis is strep viridans, which is an oral sourced bacteria. You give them 4 to 6 weeks of antibiotics, they're not out of the woods. Unfortunately, they're not out of the woods yet. Typically, if somebody's going to relapse, it's going to be about 2 months after diagnosis. Why is it 2 months? They stopped antibiotics at 4 to 6 weeks. Give another 2 weeks after, say it's 6 weeks, no antibiotics. Give 2 weeks for that bacteria that maybe I didn't eliminate with my antibiotic course to start propagating and thriving and causing a recurrence of their infection. So that's why you see relapse usually within 2 months of therapy. But you can see, and the reason that we talk about this is, even if I admit this patient to the hospital and I start them on antibiotics right away, and a good antibiotic course that takes care of that specific bacteria, I still have a 20 to 25%, so 1 in 5, 1 in 4 chance that they're going to die in the hospital from this infection. If they survive, they still are not out of the woods. The 6-month mortality rate is a little higher, so 22 to 27% mortality rate at the 6 months. So that prognosis is not very good at the 6 months. If they're an IV drug user and they're infected with Pseudomonas or a fungal source, you're looking at a 50% mortality rate. Again, even if I start them on the proper regimen, there's a 50% mortality rate in that patient. And if I don't diagnose this, I'm not suspicious for infective endocarditis, I don't apply my modified Duke's criteria, I don't do the TEE, I don't get the blood cultures, I don't do any of those things, that patient will die. And there's 100% mortality. People don't spontaneously recover from infective endocarditis. Okay? It requires treatment. So let's finish up now talking about prophylaxis. So we talked about treatment, we talked about prognosis. How do I prevent this from happening in the first place? How do I target those who are at risk? Because am I going to do prophylactic therapy on anybody coming in for potentially a high-risk procedure? When I say high-risk procedure, typically it's dental procedures that involves manipulation of the gum tissue, so their gingival tissue. That's the procedure that typically puts somebody high risk of developing infective endocarditis. So how many patients undergoing procedure with the dentist require antibiotics before they even go see the dentist? Very few. But how do I know which one of those patients actually would benefit from that prophylactic antibiotic regimen? Well, let's look at the risk factors. So if they have a prosthetic heart valve, or there's some kind of prosthetic material inside the heart, they're at high risk. They need prophylactic antibiotics before they get that high-risk dental procedure done. Left ventricular assist devices or implantable heart, yeah, that puts them at high risk, but I would also argue that unless it's like a dental emergency, they probably shouldn't be getting something like that done because they are so sick that they need an LVAD. Probably not a good thing. If they've had endocarditis in the past, it makes sense. If you've had it once before, you have a higher chance of having it again. So those patients should receive prophylactic antibiotics. And then we're going to talk about on Friday congenital heart disease, but if you have somebody who has an active congenital heart disease that hasn't been addressed yet, or it was recently addressed within 6 months, then that person should be on prophylactic antibiotics before they do high-risk dental procedures. Okay. So what are we going to do? We've identified those high risk, they've identified those who need a prophylactic antibiotic regimen before they get high-risk dental procedures done. Which antibiotic am I going to choose? Kind of depends on their allergy. If they have no antibiotic allergies, then a 2-gram dose of amoxicillin usually is adequate before they go get their dental procedure done. If they are allergic to penicillins, then we do have things like cephalexin or Keflex or the macrolides that they can be used as well. And typically, you only need an oral dose. You don't need an IV dose of these medications to do it. So that's what the regimen we typically will give to folks for prophylactic antibiotics. Questions on that before I continue our clinical case from the beginning of lecture? Okay. Told you I might need only 10 minutes more than 50 minutes, so we'll be done right on time. So remember I said that the patient started to develop this weird rash, and the nurse had kind of alerted me to it. Well, the one on the left was painless. They were Janeway lesions. The ones on the right were painful, and those were Osler nodes. Okay? And then the feet were petechiae because her platelet count had dropped to 40-something thousand. So she was developing petechiae. So she was actually sicker than she actually looked. And this was at 6:30 in the morning. I didn't have an attending in the hospital to oversee me, to help me. So what did I do? I started making calls. I called the infectious disease doc and asked him to come take a look at the patient. He was on his drive into the hospital. Of course, it's DC traffic, so he was stuck. And it was a little delayed getting to the hospital. But he told me to go ahead, start on a typical sepsis protocol by doing the Zosyn or the piperacillin tazobactam and vancomycin just to kind of cover his face, and then he would go see the patient when he got to the hospital. He ultimately started looking and diagnosed the patient with toxic shock. What's toxic shock? We normally affiliate toxic shock with tampon use, right? It's a postmenopausal woman. What's the chances she's using tampons? Unlikely. But she had a vaginal estrogen ring for postmenopausal symptoms. And the version of the estrogen ring, I don't know if anybody's heard of the Nuva ring or the contraceptive vaginal ring, that's like you leave it in for 3 weeks, take it out for a week, put another one in for 3 weeks, right? The vaginal estrogen ring was a 90-day thing. She had to leave this thing vaginally for 90 days. That's a typical prescribing course. She was at 91 days when she came into the hospital. The only reason she didn't replace it at 90 days was because she was so sick, she couldn't replace it. Okay? So she didn't deviate from the prescription. It's just she had an indwelling vaginal foreign body that led to toxic shock, which unfortunately the toxic shock was MSSA, and that gained access to the bloodstream. For whatever reason, she had damage to the endocardial surface, and it led to her developing infective endocarditis. We suspected toxic shock plus infective endocarditis based on what we saw, so we consulted cardiology. Cardiology came and said, yes, we agree this is probably infective endocarditis. Let's go ahead and do that transthoracic echo. They did the transthoracic echo. It was negative. There was no vegetation seen on the heart valve or any of the structures. So now we're like, okay, we suspect it's infective endocarditis, but we don't see it, so let's just continue the antibiotics to treat this bacteria. Well, she continued to remain sick. She continued to remain febrile. Her white counts were not improving. They actually were getting a little worse. Her platelet counts was kind of dropping. And then she started to develop new pains around her body, which part of it we were like, well, maybe it's just because she's been sitting in bed for such a long period of time. But then this was over the course of a week of her getting antibiotics, and also a week of persistent positive blood cultures. So she was still shedding bacteria that was not being fixed by the antibiotics we were giving her, even though the sensitivity said that those antibiotics should have worked. So we were questioning, and cardiology's like, no, we don't feel like we need to do a transesophageal echo for this patient because we don't think that this is a surgical case. We think we just need to continue antibiotics. I suspect kind of a driving factor for why they didn't want to do a TEE was because of her platelet count. If their platelet count's low, it's going to be at a much higher risk of bleeding. And what's the chances of bleeding as I'm trying to pass a semi-rigid scope through the esophagus and the stomach, right? Probably very likely. So, so we decided, well, we don't know what's going on. The x-rays of the body parts that are hurting are normal. Let's go ahead and do a PET scan. This is her PET scan. So you should have here in the bladder, that should light up. The IV here, that should light up, and the brain should light up. Every other black spot should not be there. What had happened is that vegetation kept chipping off and sending emboli everywhere over the body, including into the bones themselves. So she basically had like this osteomyelitis from the septic emboli eating away at the bones. And so the knee pain she had, which you can kind of see down here, right here, is a septic emboli. Look at her shoulder. That's a septic emboli. Multiple septic emboli that went to the shoulder that was eating away at the bone. And, oh, by the way, there's a 1.2 centimeter vegetation on the mitral valve. that was invading the ventricular septum. So we saw that, and guess what we did? Well, we don't have cardiothoracic surgery here at Fort Belvoir. We're transferring you to Walter Reed so you can go see the surgeons. They went in, they did a valvuloplasty, so they fixed the valve, and they got rid of the vegetation as it was invading the interventricular septum. And at about the 4-week mark, she was still alive, still on heavy antibiotics and everything, but she wasn't necessarily out of the woods yet. So this is why infective endocarditis is, one, a very difficult condition to treat, but two, a difficult condition to diagnose because a lot of times the symptoms are very vague until there's a complication that develops. And three, it also illustrates why you need to do your testing when it's clinically safe for the patient. If we had gotten that TEE sooner, we may have been able to get treatment earlier before some of the complications from those septic emboli had developed. So a pretty complex patient, and you can kind of see something like toxic shock in and of itself is deadly, but then can lead to other complications because of that. So, and then we have now talked about one of the topics that we need to for the PANCE blueprint, so we can mark that one off. I promise you we will start marking these off a lot faster, but we did mark one off, and so we're making some progress. So, questions? All right, that's all I've got for